Can we start, Mardi? Okay.
Yes, Doctor.
Okay. Good evening, dear members. Welcome to the third ERC for this fiscal year. I hope we will enjoy this meeting. So to start today's activity, let us have the invocation, then followed by the national anthem. Okay, can we play the invocation followed by the national anthem?
Invocation followed by the national anthem.
Pambansang awit ng Pilipinas.
Kayang magiliw, kasasilamanan, alam ng puso, sa likid mo'y buhay. Upang hinirang, kuya ka ng magiting, sa manlulupin, di ka pasisingil, sa kanang tulog sa simoy at sa langit ng pagkaw. Ay hinanang tulang, awit sa pagkayang minamahal, ng isa ng matawag ko'y tagumpay na nagtinig. Mapituloy na parang niya kailan ang hindi magtitinig. Luman ang araw ng walang pagsinta, ay langit sa piling mo. Aming ligaya ng pagkay pag-aami, ang matay ng dahil sa'yo.
So next to our program is the welcome remarks, which will be given to us by none other than the President of the PSDE, Dr. Benjamin Geraldo Perez. Benji?
Good evening. Sorry, my video doesn't seem to be working. I already put it on. Mardi, Can you see why my videos are not being shown on the screen?
Doctor, right now, hindi po.
My video is already on. Teka. Yeah, mako-on ang video ko. I don't know why I cannot be seen.
I mean, sometimes, Doctor, it's something to do with the connectivity.
Okay. At any rate, I'll just good afternoon and good evening. Welcome to another ERC, where once again 2 training institutions will each present a case with important learning points in correlation between clinical gastroenterology and endoscopy. In this era of a worldwide pandemic, going online has allowed us to reach more members to enhance their learning. I hope everybody will be able to pick up something from this, even our more experienced members. And I thank Makati Medical Center and De La Salle University Medical Center for being the host for today's ERC. Thank you for attending and good afternoon.
So thank you, Dr. Perez. Now to give us the first opening remarks, he's the section head of the gastroenterology of the Makati Medical Center. My friend, a ever good-looking guy, Dr. Ernesto Olympia. Sir.
Thank you, Julius. Good afternoon, everyone. Although in a little while, it will be good evening. The Makati Medical Center, in partnership with De La Salle University Medical Center, do welcome all of you. This scientific activity is a manifestation of the society's strong passion to continue our education. To our sponsors, to the facilitators, to the speakers, I'd like to say thank you. Kamsahamnida. Okay.
Thank you, Dr. Olympia.
Thank you, Julius.
So next to give her opening remarks will be the section head of gastroenterology of the De La Salle University Medical Center, the ever charming Dr. Dina Perez. Good evening po, Doktora.
Charming Perez na ako ngayon, Gonzales.
Dr. Gonzales. Sorry. Excited lang.
A pleasant day to everyone on behalf of the section of gastroenterology of the De La Salle University Medical Center and of course our charming partner, the Makati Medical Center. I would like to welcome you all into the unknown. This theme is highly timely as we are faced with a formidable invisible enemy. To relate the theme to today's ERC from our end, as gastroenterologists and gastrointestinal endoscopists, we are from time to time faced with cases that we know to be either common or not so common or rarely uncommon. We think we know how to approach them by way of what is written in the textbook or utilizing evidence available in the literature, but an actual encounter with a patient can be sometimes for so many reasons, like exploring into the unknown, especially for the fellows in training, and sometimes also to us, the trainers. Thus, I am grateful to our society officers, our hardworking PSDE officers, and the dedicated training committee as well for going all out and sustaining these important learning activities online so that we can all be armed and confident in our journey into the unknown. Again, welcome and enjoy the conference. Thank you, Julius.
Thank you, Dr. Gonzales. Now, let me introduce the reactors for tonight. First reactor will be Dr. Wilmer Hababa, but unfortunately, he's not feeling well today, so let's pray that he will get well soon. So our second reactor is from East Avenue Medical Center. She is a graduate of De La Salle University College of Medicine. She had his training in internal medicine at San Juan de Dios Hospital and fellowship training in gastroenterology at East Avenue Medical Center. She also has a master in management, major in hospital administration. She is presently the training officer of the gastroenterology fellowship training program of the East Avenue Medical Center. And also she's the chairman of the therapeutics committee at San Juan de Dios Hospital. So Dr. Sarah Preza Carmona. Doctora, can we see you and wave at us?
Hi, sir. Hi, everyone.
Ano ba,
Good
sir?
evening.
Okay. So next will be the next reactor. We are very fortunate. We have a radiologist with us. He is from Makati Medical Center. He had his fellowship at New York University Medical Center, and he is presently practicing at Makati Medical Center as an interventional radiologist. Dr. Jackson D, are you here now?
Yes, I'm here.
Okay, thank you for joining us. So now just a few reminders. Only the reactors are allowed to ask the questions verbally, and they need to click the raise your hand button in the Zoom app to be recognized. The rest of us, the audience, if we have questions, we have to put our questions on the chat box, okay? So now let me introduce the moderator. So our moderator is a graduate of the, he's from University of Perpetual Health Rizal School of Medicine. He graduated valedictorian. He had his internship at PGH, and he had his fellowship in gastroenterology at Maddox Hospital, and had his fellowship in advanced therapeutic endoscopy at the University of Malaya Medical Center, Kuala Lumpur, Malaysia. Presently, he's a board member of PSDE. He is the committee head of the basic and advanced endoscopy training of the PSDE. He is the head of the endoscopy unit of the De La Salle University Medical Center, and he is the vice chairman of Department of Medicine, Perpetual Health Medical Center. And he's also an associate professor in the Jonaltan Foundation School of Medicine, University of Perpetual Health Delta Systems. So another very good-looking guy. Are you there already? Are you here already, Dr. Ronald?
Yes,
Romero?
sir. Good evening, everyone. Thank you, sir.
Okay, Dr. Romero, take it away.
So we'll start with the first institution. I call on Dr. Mark Chato from Makati Medical Center to present their ERC case.
So good evening, everyone. I am Mark Palachato, first-year gastroenterology fellow at Makati Medical Center, and I'll be presenting our case for ERC. We have a 26-year-old male Filipino from Makati with a chief complaint of hematemesis. Initially at age 16, in 2007, he came in with generalized crampy abdominal pain, right lower quadrant, which was initially thought to be appendicitis, but on CT scan, no appendicitis was found. Instead, what was found was nodular liver margins with splenomegaly and collaterals, probably portal hypertension. So the patient was assessed with liver cirrhosis and he was worked up. As you can see, for slightly elevated AST and ALT, liver function was relatively well preserved. Workup for Hep B and C was negative. CBC showed thrombocytopenia and normal iron studies. Workup for metabolic syndrome was done, showing diabetes and mild dyslipidemia. EGD was done at this time to determine if there were varices, but none were found. So the patient was worked up with, assessed with cryptogenic liver cirrhosis, portal hypertension, obesity, and dyslipidemia. He was given propranolol, and which was shifted to nebivolol because he couldn't tolerate the propranolol due to bronchospasm. After this, he was lost to follow-up. On the interim, the patient was relatively well with good functional capacity of ECOG 0, except for increasing abdominal girth and prominent vessels in the periumbilical area. He had no other symptoms. 3 years ago, at age 26, the patient remained with painless hematemesis for 3 episodes without jaundice, edema, or mental status changes. Consult at the ED showed anemia of hemoglobin 7, thrombocytopenia platelet 45 with microcytic pattern, although he was hemodynamically stable. The upper GI bleeding was thought to be secondary to varices because the patient was thought to have liver cirrhosis at that time, decompensated CTP-B7 meltdown. The review of systems was unremarkable. The patient only had bronchial asthma but was controlled. He has no previous surgeries, no maintenance medications, no herbal medication intake, no noted childhood developmental delay. He had physiologic jaundice but no persistence after phototherapy. After a week, he is a non-alcoholic beverage drinker and denies occupational exposure. There is no history of liver disease in the family, autoimmune disease, or blood dyscrasia, and the mother is non-hepatitis reactive. On PE, the patient is obese, BMI 31, not an NSF, normal vital signs. He has no jaundice, pulmonary arrhythmia. He has anecteric sclerosis, no gynecomastia or spider angiomata. His abdomen is globular with caput medusae. Yet there is no shifting dullness with a palpable spleen. The liver edge is nodular, and the DRE did not show any hemorrhoids. So for our first poll question, what will be your priority?
For the first poll question, what will be your priority at the ER? Kindly key in your answers, and we'll see. We'll give 30 seconds for this. Okay, 30 seconds is up. Let's see the results. So 85% answered letter B, medical resuscitation, followed by diagnostic imaging. So kindly continue, Dr. Mark. Did you see the results?
Yes,
sorry.
yes, sir.
Yeah.
Well, the answer is medical resuscitation.
Yeah. You may continue, Dr. Mark.
Okay. This is the answer is medical resuscitation. So from the ESOL guidelines, the first thing to do when a patient comes in with bleeding portal hypertension is to resuscitate airway, breathing, and circulation. So the initial impression at this time is upper GI bleeding, probably secondary esophageal varices, portal hypertension, and decompensated liver cirrhosis. So after the patient was resuscitated, he was brought to endoscopy. At this time, there were 2 columns of prominent tortuous vessels occupying less than 1/3 of the esophageal lumen, located in the distal esophagus. On the rightmost picture, there's note of red whale sign at the distal esophagus, approximately 0.5 to 1 cm from the EG junction, showing stigmata of recent variceal bleeding. The proximal and mid-esophagus were unremarkable. For the second poll question.
In the event that the bleeding persists despite endoscopic band ligation and maintenance with vasoactive drugs, what is your next step? So key in your answer now, everyone. Okay, we'll see the results and I'll share them. So majority answered transhepatic intrajugular portosystemic shunt, followed by repeat RBL and balloon tamponade last. Can you discuss the answer, Dr. Chato?
Okay, so the answer is So the answer is TIPS. Again, from the same algorithm from ESOL, published in the Journal of Hepatology in 2018. So as you can go through the algorithm, once we do RBL endoscopic band ligation. And if the patient has still has bleeding and you maintained on vasoactive drug therapy for 3 to 5 days and there's further bleeding, ideally we rescue with tips. Now, we can do a balloon tamponade or esophageal stenting, but this is only a temporary and a bridge to tips ideally. So this is a video of our endoscopy. So upon reinsertion of the scope with rubber band, there was note of bleeding in the varices. Identification of the varix was done at the most distal part above the Z-line. The tip of the scope was placed perpendicular to the wall of the esophagus. Suctioning was applied until the varix completely obliterated the field or read out. A total of 4 rubber bands were deployed from the distal esophagus upwards proximally every 1 to 2 cm in a spiral fashion. On reinspection, as you can see in the images on the right, bleeding was noted. So the gastric mucosa was noted to be pale and coarse with mosaic pattern, consistent with portal gastropathy, with several hematine stains noted at the body and antrum. On retroflexion, the scope was adequately hugged by the cardia with no gastric varices. So the patient was lost to follow-up in 2007, where he wasn't found to have any varices. He underwent surveillance yearly from 2017 to 2020 for the last 3 years. Bleeding varices were noted in 2017 and 18, but none in 2020, and he was compliant to carvedilol throughout this time. On repeat EGD in February 2020 this year, one can see significant diminution in size of the varices compared to baseline in 2017. There was no red whale sign noted in the distal esophagus, and the proximal and middle esophagus were unremarkable. The stomach had some mild gastric varices noted in the fundus with no signs of bleeding. The image of the antrum shows evidence of portal gastropathy due to the mosaic pattern of the mucosa. And there were some areas of pinpoint erythema in the body and antrum as well. The rest of the findings in the pylorus and duodenum were unremarkable. So to discuss our imaging, I call on our radiologist from our center.
Good afternoon. Hello? Yes?
Yes,
This is Dr. Peña from Makati Medical Center under Dr. Jackson D, resident. Okay. First, we'll be discussing the ultrasound and CT scan of patient. This is an ultrasound of the upper abdomen with shear wave elastography done in 2017. The images on the left show the liver normal in size but regular and nodule margins. There's also evidence of dilated portal veins measured 15 millimeters, shown here in the images in the right. Shear wave elastography produced a score of 1256 kilopascal with a metabolite score of F4, indicating liver cirrhosis. Next slide, please. Next is the same ultrasound, but then the image in the left demonstrates dilated hepatic and periumbilical veins as shown in Doppler. The image in the right shows an enlarged spleen measuring 19.7 by 19.3 by 7.0 centimeters with a computed splenic index of 1,583. This was signed out as liver cirrhosis with evidence of hypertension, with features such as splenomegaly and periumbilical/perihepatic vessel formation. Next slide. Next, the color Doppler of the portal vein, done 2018. This is the ultrasound of the portal and hepatic veins with color done in 2018, showing a dilated portal vein with normal color Doppler flow in the portal and hepatic veins. Next slide, please. Next, fibroscan done back in 2018. We have a liver stiffness value of 16.4 kilopascal, previously 12.56 kilopascal last 2017, with a metaverse of F, still indicating liver cirrhosis. CAP score, which means controlled attenuation parameter, score for steatosis was 240 deaths per meter, indicating no steatosis. This is signed out as liver cirrhosis, no evidence of hepatic steatosis. Next slide, please. Next, the CT scan done back in 2018. Now, there is subtle nodularity of the liver margins, as you can see, the liver, scan of the liver. And then the spleen is 181 by 93 by 202 with a splenic index of 1,905. The main portal vein is dilated with the umbilical vein and multiple and tortuous portosystemic laterals and veins forming the caput medusae sign. Next.
So for our third question, we have the poll.
For the third poll, the presence of this radiologic finding in our patient is strongly indicative of the presence of what condition? Key in your answers, and we'll look at the poll. Majority answered portal hypertension, letter B, followed by umbilical varices, letter C. May continue, Dr. Chato.
Okay, so the answer here is portal hypertension. Dr. Pena.
Okay, next is an additional image just showing the splenic varices. Image on the left is the portovenous phase, and the image on the right is the arterial phase, which is the enhancement on the splenic veins to the varices. Okay, next slide, please. Here's the measurement spleen as mentioned before, and here in image on the right just shows the incidental finding of an anterolaterally directed right renal hilum, as pointed by the arrow. Now, this was signed out as liver cirrhosis and portal hypertension, as evidenced by marked splenomegaly, dilated portal vein with recanalization of the umbilical vein, as well as the portosystemic collateral vessel formation, and malrotated right kidney. Next slide, please.
Hi, good afternoon. This is Dr. Peralta, also a resident under Dr. Jackson D. So for the MRI images, this is an MRI of the upper abdomen with contrast dated February 23, 2020. So in this image here in the left, it demonstrates nodular liver contours, whereas the image on the right demonstrates markedly enlarged spleen. Next slide, please. So this is the same MRI of the upper abdomen. Here are T1 weighted images with contrast. The image on the upper left is the plane sequence. Image on the upper right is the arterial phase. Image on the lower left is the portal venous phase or venous phase, whereas the image in the lower right is the delayed phase. So these images show no significant change in the dilatation of the main portal vein with recanalization of the umbilical vein, as well as multiple dilated and tortuous portosystemic collaterals. Next slide, please. These images are again taken a bit more caudally, which further illustrate the presence of periumbilical collaterals, which also form the so-called medusae. Next image, and next slide, please. So here, we see here innumerable non-insane low T1 weighted signal foci scattered in this, as you can see here. So this case was signed out as liver cirrhosis, evidence of portal hypertension with recanalization of the umbilical vein and splenomegaly, as described in the previous studies. Now, the low T1 weighted foci scattered in the spleen likely represent again the bodies, or in other terms, splenic sideronodules, These are mostly encountered in cases of portal hypertension, and they result from microhemorrhage resulting in hemosiderin and calcium deposition in the splenic parenchyma, seen as low signal foci in all sequences. Next slide, please.
Okay, thank you, doctors. So for our patient's clinical course, our patient's liver function was monitored over the last 3 years. And as you can see from the trends, the patient's liver function is relatively well preserved. He had 2 episodes of bleeding varices in 2017 and 2018, controlled by carvedilol. He was given insulin for diabetes as well. Repeat workup for hepatitis panel was negative, so he was given vaccination for Hep A and B. He was maintained on carvedilol, and annual endoscopy was done for surveillance of varices. Workup for autoimmune liver disease showed mildly elevated positive ANA, but negative anti-SMA and negative anti-mitochondrial antibody. Serum IgG was negative as well as the lupus panel. Workup for hematology showed that his blood derangements were secondary to hypersplenism, as shown by his bone marrow aspiration findings. He was given L-Thrombopag. As you can see, he had thrombocytopenia. He was given L-Thrombopag for this, but he was unable to sustain it due to the cost. Workup for Wilson's also showed normal ceruloplasmin. Endocrinological assessment at that time was diabetes mellitus type 2, for which they only gave insulin. Ideally, we would have wanted liver biopsy to ascertain the etiology of his cirrhosis and portal hypertension, but due to thrombocytopenia, percutaneous method was not done. We offered transjugular liver biopsy, but this was deferred as well due to the financial constraints. So to summarize, our patient is a 26-year-old male, Filipino, obese, with diabetes mellitus type 2, with a history of portal hypertension and cirrhosis since age 16, with a relatively benign clinical course. He has no history of drug intake or viral hepatitis, no drug or toxin exposure, relatively well, good functional capacity, no history of childhood developmental delay. He has portal hypertension and without stigmata of liver cirrhosis on PE. The imaging is consistent with portal hypertension, splenomegaly, and cirrhotic liver, which is stable over the past 10 years. Of note, there is no polycystic kidneys, there is no steatosis on FibroScan. He has relatively well-preserved liver function for the past 10 years despite his portal hypertension. He is negative for viral hep, ANA is mildly positive, but negative anti-SMA, AMA, lupus panel, and IgG. There is normal ceruloplasmin and normal iron studies. So our final impression is cryptogenic liver cirrhosis, portal hypertension, possibly congenital hepatic fibrosis, bicytopenia secondary to hypersplenism and diabetes mellitus type 2. A multidisciplinary meeting was done, and this patient should get liver biopsy. He was also referred to surgery for possible splenorenal shunting or splenectomy. If the transjugular liver biopsy will be too expensive for him, then we can do an intraoperative liver biopsy during the surgery. He's also sent for liver transplant evaluation with genetic workup and immunization prior to the possible splenectomy. For discussion, we have a 26-year-old male patient, adult male, who presented with signs of portal hypertension and cirrhosis of the liver since age 16, but with preserved liver function. To approach our case, we had to identify the cause of portal hypertension. Is this prehepatic, intrahepatic, or posthepatic? So for prehepatic, this patient has no evidence of thrombosis on multiple imaging modalities. For posthepatic, he has no mild proliferative or hypercoagulable states which can predispose him to Budd-Chiari syndrome. There's also no evidence of this on multiple imaging. The patient does not have any signs or symptoms of heart failure, so this makes this unlikely. So we are left with intrahepatic cause. So the table shown here shows the main causes of chronic liver diseases presenting in the pediatric age group. Our patient presented at age 16, but is negative for viral hep. His autoimmune workup only showed mild ANA positivity, but negative for other markers which could indicate autoimmune liver disease. Patients with biliary atresia will usually present at the first few weeks of life with persistent jaundice, but our patient did not have that. He also has no biliary findings on imaging. Patient does not live in an endemic area for schistosomiasis, and there are no classic findings such as pipe stem fibrosis on imaging. He has no drug or toxin intake or exposure. And patients with cirrhosis due to NASH will usually take years to develop and is usually seen in older age groups. And for the metabolic angle, he has unremarkable childhood developmental history, he has unremarkable review of systems, negative family history, and normal ceruloplasmin and normal iron studies. So you're left with fibropolycystic liver disease. So fibropolycystic liver disease encompasses hepatic ductal plate malformations characterized by variable degrees of periportal fibrosis and irregular proliferating bile ducts. These include congenital hepatic fibrosis, hamartomas, and Caroli disease. As you can see from the table, biliary hamartomas and Caroli disease would have features of biliary involvement in radiologic imaging, but our patient had none. He had nodular liver margins, but no biliary ductal dilatation. So this makes these diagnoses unlikely. In our journal search, we found that for patients with congenital hepatic fibrosis, they initially commonly present with signs or symptoms related to portal hypertension, especially splenomegaly and varices, often with spontaneous GI bleeding. CHF is a rare developmental disorder. It is recessive, autosomal, expected to occur in every 1 to 20,000 live births. The onset of symptoms and signs is highly variable and ranges from early childhood to the 5th or 6th decade of life, although this disorder is diagnosed in most patients during adolescence or young adulthood. The clinical manifestations of congenital hepatic fibrosis is nonspecific. It's often confused with cirrhosis because of the extensive fibrosis seen on biopsy and portal hypertension. Liver function tests may remain normal or only modestly elevated as seen in our patient. He has both preserved hepatic function and also features of hypersplenism. So the distinguishing feature of CHF is preserved hepatic function despite portal hypertension. However, for patients with CHF, normally since this is a fibropolycystic disease, it is often concomitant with renal disorders, particularly autosomal recessive polycystic kidney disease. But this was not seen in our patient. Usually renal involvement will be diagnosed earlier in neonates and infants, and liver-related problems will be more common in older children, diagnosed in older children or adults. The gold standard for CHF is liver biopsy. So extensive hepatic fibrosis can be seen with widened portal tracts with bands of fibrous tissue, irregularly shaped narrow and elongated bile ducts, and periportal fibrosis without inflammation. However, as you can see on the image on the right, hepatic parenchyma is normal. So this is why liver function is generally preserved. The management of CHF is directed towards treating the complications, and liver transplant is the only known cure, especially for those who develop signs of liver failure. As a take-home point, liver cirrhosis is a complex disease involving multiple organs. We have to reevaluate differentials for diagnosis, especially for young patients. The management of portal hypertension and complications require multidisciplinary expertise and consult, and early specialist referral and timely intervention is crucial. Thank you.
Thank you, Mark from Makati Medical Center. May we now call on our first reactor, Dr. Sara Preza, to give her comments on the case.
Hi, good evening. Most of my questions were already answered by the presenter, but I'm just going to give some of my points. This is really, first of all, congratulations to our presenter for a very nice presentation. You have extensively discussed the case. It is really indeed an interesting case and with a peculiar presentation, as we seldom see cirrhosis with portal hypertension in the young. Now, really establishing the diagnosis is essential. Hence, this patient was extensively worked up as evidenced by the repeated ultrasound, CT scan, MRI, and even Doppler study of the portal venous system. But despite all those diagnostics, we are still left into the unknown. As of this time, we still don't have still have the definite diagnosis for the etiology of the cirrhosis of this patient. I agree, liver biopsy is really important and must be done in this case to establish the diagnosis as it is the gold standard for the diagnosis. I think one question was that this patient was planned to have liver biopsy at year 2019, but the platelet count was only 33,000. But during your monitoring of the CBC, there was one window that the patient has 60,000 platelet count. So I was wondering why was the liver biopsy not done at this point or at this time. So it would have been very crucial if the liver biopsy wasn't at that time. Now, despite all the long list of etiologies of cirrhosis, there are still about 5 to 15 cases of cryptogenic cirrhosis. So, another problem with this patient, I think ang question ko, my question was dun sa management of portal hypertension. So, at the protocol that you were given, that there was no mention that you had repeated you had obliterated the varices by repeated endoscopy. I don't know if it was omitted, but I wasn't able to see that in the protocol. So that was one of my question. Why proceed with the surgical shunting without doing the repeated endoscopy to obliterate the varices? If surgical shunting cannot be done due to the low platelet count, is TIPS an option? And if TIPS is an option, can we do also the biopsy during TIPS placement? So that's it.
Really comment, Mark? Or okay, so there are several questions in the chat box, and we still have a few minutes before we move on to the next case. I will try to ask the questions that are similar or related to each other. So the first question, Mark, why cryptogenic cirrhosis? What's your basis for labeling this patient as cryptogenic? And is it type 1 or type 2? Or is there a significance or any difference if it's type 1 or type 2?
Cryptogenic because we don't yet have the initial, we don't have the definitive cause of this patient cirrhosis, doctor. So ideally, that's why you would have wanted to do liver biopsy to more definitively elucidate the etiology of the cirrhosis. So,
okay. And the type of diabetes, will it matter if it's type 1 or type 2? No, okay.
Probably
yeah. Another question is, beta blocker was initially given to this patient even after a normal esophagus on initial endoscopy. You were not able to appreciate esophageal varices on the initial endoscopy, right? And yeah, that was the question.
This was part of his prophylaxis. This was given from another doctor. So he was given that as a prophylaxis for development of varices. However, he wasn't able to tolerate it at that time.
Yeah, I think the question is directed because we know that beta blockers are given for primary prophylaxis for variceal bleeding in patients with esophageal varices. No? But I think there is evidence on CT of portal hypertension. So does that warrant for you to give beta blocker even if you don't have esophageal varices? Okay. Portal hypertension on imaging, is that an indication to give beta blocker?
Yes, doctor.
Okay, so next question. No? Since this is an ERC, no? ERC means the objective is to correlate your endoscopic findings with radiologic imaging, and if histology is present, you also correlate. So the question here is, can you correlate your FibroScan results or findings with that of your CT and MRI findings? Are they consistent with each other, and are the findings consistent with your impression of cirrhosis?
Yes, because the FibroScan showed cirrhosis, and then the CT and MRI showed nodular liver as well. So there was in the CT MRI earlier, they showed the nodularity of the liver in the imaging, doctor. So that's cirrhosis, and then the FibroScan was also indicative of cirrhosis.
Okay, so for the last question, it's more on the training side. In your institution, do you read FibroScan and CAP results as fellows in training, or the radiology section do the reading?
They do the reading po, Doctor, pero we also read it po, Doctor. So whenever we do whenever we have patients for ultrasound, not only do we read the ultrasound but also the fibroscan. We try to interpret it. Parang X-ray, Doctor.
Yeah, I think it's a very easy procedure to do, and the results, if you just read it and compare it in a table, a reference table. Yeah. So that summarizes the questions in our chat box. Thank you, Dr. Mark Chato from Makati Medical Center. And now we move on to the second institution to present their ERC case. May I call on Dr. Mark Pasqua from De La Salle University Medical Center to present their ERC case.
Good evening. I am Dr. Mark Ryan Pasqua, Senior GI Fellow from the De La Salle University Medical Center, and I am here to present the second ERC case. Our objectives include to present to patients with dysphagia, correlate their clinical presentation with radiographic and endoscopic findings, and discuss the endoscopic management of the given cases. Our first case is AS, a 25-year-old male complaining of dysphagia. History revealed that 3 years prior to admission, he began to experience heartburn and regurgitation. He sought consult and was prescribed with proton pump inhibitors, which afforded partial relief. He then underwent an EGD and was diagnosed and treated for H. pylori gastritis. In the interim, he noted intermittent heartburn until 1 year prior to admission. He developed progressive dysphagia to both solids and liquids, and this was associated with a 4-kilogram weight loss. Regurgitation is still with heartburn, but there was no associated fever, chest pain, abdominal pain, or hematemesis. Due to persistence of the symptoms, he sought consult at our institution for further management. He has no history of tuberculosis, comorbidities, nor previous surgeries. Family history was unremarkable. He is a non-smoker, non-alcoholic beverage drinker with no history of high-risk sexual behaviors. On physical exam, he is underweight with a BMI of 17, but the rest of the physical examination was unremarkable. To summarize our first case, we have a 25-year-old male with history of heartburn and regurgitation, now with dysphagia to solids and liquids, and weight loss. Dysphagia can be approached using this diagnostic algorithm from the latest edition of Schlesinger, with our focus on esophageal dysphagia. When a patient experiences dysphagia to solids alone, which is progressive and without weight loss, the differentials include caustic stricture, diverticula, and peptic stricture. But in the presence of weight loss and advanced age, cancer should be suspected. If intermittent dysphagia to solids alone is present, consider eosinophilic esophagitis or rings. On the other hand, when a patient has dysphagia to both solids and liquids, considerations include achalasia, Chagas disease, scleroderma, and other motility problems. And since our patient presented with dysphagia to both solids and liquids, this leads to our initial impression of primary achalasia.
For the first poll question, based on the ACG guidelines, what is the initial step in evaluating patients suspected of achalasia? Barium esophagogram, EGD, manometry studies, all of the above. Key in your answers now, please. Okay. For the results, most answered barium esophagogram, followed by EGD and manometry last. Go ahead, Mark.
So in the diagnosis of achalasia, the American College of Gastroenterology recommends EGD for initial evaluation of patients suspected with achalasia. This is used to primarily to rule out mechanical obstruction or pseudoachalasia. An esophagogram, on the other hand, is useful to assess late or end-stage achalasia, such as the sigmoid type, and is supportive for a diagnosis. Manometry is the confirmatory test and is considered the gold standard for the diagnosis as it will determine achalasia subtype and predict treatment outcome. These three tests, when available, are complementary and should always go hand in hand with clinical suspicion. So our patient underwent an EGD after being fasted for 12 hours. Upon scope insertion, significant pooling of saliva was noted and removed by endoscopic suction. The esophageal body was noted to be dilated, and the LES was observed to have a puckered appearance. It was traversed with some resistance, but the cardia and the rest of the stomach was unremarkable. So these are the still images of the EGD done. A barium esophagogram was done to present, and to present the findings, please welcome our Chief Radiology Resident, Dr. Janine Baclao.
Hello, good afternoon. I am Dr. Janine Baclao from the DLSUMC Department of Radiology, here to present to you the imaging findings of our patient. So this is the esophagogram done last February 2020, showing, next slide please, diffuse dilatation of the esophagus, measuring approximately 6.2 cm in its widest diameter. Next slide please. There is slow passage of the contrast into the stomach with small spurts of barium entering the gastric lumen through a narrowed distal segment exhibiting a conical rat tail appearance of the gastroesophageal junction. No evident mass lesions, irregular filling defects, or extraluminal extravasation of the contrast material was noted. Next slide, please. The late study then shows complete passage of the contrast into the stomach with no evidence of reflux or reflux of contrast material. The aforementioned findings are consistent with achalasia.
Thank you, Janine. A high-resolution impedance manometry was done to this patient, and as a primer, manometry is done using a nasally inserted catheter with pressure sensors to perform continuous recording of esophageal motor activity. It gives us a color contour plot which represents a normal swallow as shown here. In this image, the y-axis indicates esophageal length with time on the x-axis. Pressures are represented by colors, with blue depicting low pressure and warmer colors as high pressure areas. At the top, we see a wide band of pressure which represent the upper esophageal sphincter. At the bottom is the lower esophageal sphincter. This period signifies upper esophageal sphincter relaxation or the initiation of swallow. The transition zone associated with striated to smooth muscle transition is then followed by peristalsis. This low pressure area coinciding with peristalsis is LES relaxation to complete a normal swallow. There are several parameters used in manometry, but given our case today, emphasis is on the integrated relaxation pressure or IRP, which reflects the ability of the LES to relax. In normal IRP is less than 15. There are three subtypes of achalasia determined by manometry, which possibly relates to the various stages of the disease. Type 1 is classic, where there is no peristalsis and no LES relaxation. Type 2, or the compressive type, is the most common, which have normal bands of pressure-colored green with no normal peristalsis or LES relaxation. Type 3 or the spastic type have high pressure spasms but do not resemble a normal peristalsis. A manometry was done on our patient at St. Luke's Medical Center, and we would like to acknowledge and thank Dr. Shelly De Ocampo for providing us the representative image. A normal pattern is shown at the left side for comparison. In our patient, the LES was non-relaxing with an elevated mean IRP of 21. A continuous band of pressure in the middle is seen with absence of a normal peristalsis. Together with the clinical endoscopic and radiologic findings, these supported our final impression of type 2 achalasia. So achalasia is a primary motor disorder of unknown etiology characterized by degeneration of the mesenteric plexus leading to impaired LES relaxation and absence of peristalsis. Classically presenting as dysphagia to both solids and liquids, regurgitation, weight loss, and chest pain. The ECARD score is a valuable tool to assess clinical symptoms and as a pre-treatment parameter. A higher score directly correlates with severity. Our patient presented with daily dysphagia, regurgitation, weight loss of 4 kilograms with a baseline ECARD score of 5. So for the next question.
For the second poll question, which of the following therapeutic options is recommended given the patient's clinical factors? Most answered pneumatic dilation, followed by botulinum injection.
Okay. So, we agree with our audience. The ACG recommends the therapy should be guided by age, patient preference, and local availability, with the primary goal of decreasing LES pressure. In this treatment algorithm, a patient with high surgical risk may be treated with Botox injection and pharmacologic therapy, while patients with low surgical risk, such as ours, options include graded pneumatic dilation, Heller's myotomy, and peroral endoscopic myotomy or POEM, with esophagectomy considered for end-stage achalasia or failed response from the first-line treatment options. Among these strategies, pneumatic dilation is an effective non-surgical option to reduce LES pressures and is widely available. This was offered to our patient. So this was the video of the pneumatic dilation session. The scope traversed the LES and was inserted up to the antrum. A piano guide wire was inserted and guide wire exchange was done. A Boston Scientific Rigiflex 30mm balloon was threaded through the guide wire via endoscopic guidance or side-by-side technique. The balloon was positioned within the LES guided by the external black markers. Then the balloon was then inflated up to 20 pounds per square inch or 1.4 atmospheres and maintained for 60 seconds. After which the balloon was deflated and withdrawn. Minimal bleeding and a mucosal tear were observed. After dilation, the scope was able to bypass the GEJ with relative ease. So the efficacy of pneumatic dilation relative to balloon size is shown in this table. In a 2019 meta-analysis, a large balloon size was associated with higher overall success rate of 90% at 6 months and 79% in a 1-year follow-up. But current conventional approach is to start with 30mm size balloon, then increase the size gradually during the predilation. In addition, repeated dilations have better short and long-term symptom improvement as compared to just a single dilation session. Patient factors that have shown favorable clinical response to pneumatic dilation include the female gender, age more than 45 years old, a narrow esophagus prior to the dilation, and those with type 2 achalasia, which was in our case. The most dreaded complication in pneumatic dilation is perforation. A 2019 meta-analysis showed perforation rates were observed to be between 1 and 9% during the initial dilation, with other adverse events including chest pain and reflux. Going back to our patient, he was discharged improved without post-dilation complications. He was able to tolerate solid foods and gained 9 kilograms. His ERC score was 1 from a previous score of 5. However, 1 month post-dilation, he had recurrence of dysphagia, wherein a repeat esophagogram was done, which will be presented by Dr. Baclav.
Okay, so this barium swallow was done last March 2020. As compared to the previous study, there is now a slightly wider distal segment of the esophagus and gastroesophageal junction. No evident mass lesions, filling defects, or extraluminal extravasation of the contrast material was noted. Next slide, please. Next slide. 5-minute delayed study showed no retained contrast material within the esophagus. Next slide, please. So here is the comparison of the esophagogram pre and post ballooning. In your left is the pathognomonic racktailing or your bird's beak sign of achalasia, while on your right, the distal esophagus and the gastroesophageal junction is now widened.
Thank you, Janine. Because our patient had symptom recurrence, he was advised a repeat dilation, or as shown in the treatment algorithm, another option, which is per oral endoscopic myotomy. Which brings us to our next case, J.A., a 28-year-old male consulting for dysphagia. His history revealed that 2 years prior, he developed gradual progressive dysphagia to both solids and liquids associated with retrosternal chest pain, regurgitation, and 13-kilogram weight loss. He underwent EGD and was diagnosed with esophagitis and treated with proton pump inhibitors, but afforded no relief. 2 months prior, dysphagia persisted and prompted patient to seek second opinion. A repeat EGD was advised. There was no associated fever, abdominal pain, or hematemesis. Similar to our first case, this patient had no other significant medical history. Likewise, physical exam was unremarkable, except for a low BMI. To summarize, we have a 28-year-old male with chronic dysphagia, retrosternal pain, regurgitation, and significant weight loss of 13 kilograms, and the baseline ECARD score of 8. Again, primary achalasia was suspected and an EGD was performed. This is the EGD of our second case. So despite being on NPO for 12 hours, retained food was seen in the esophagus. This was removed via endoscopic suction, revealing whitish change in mucosal thickening. The esophagus appeared dilated, and the LES was seen at 45 centimeters, which showed the characteristic puckered appearance. The rest of the stomach and cardia was unremarkable. So here are the still images of the EGD showing retained food, dilated esophagus, with no cardial lesion or mass. An esophagogram was also done for this patient and will be described again by Dr. Baclav.
This is the barium swallow done to the patient at another institution last July 2019 with the following findings of a dilated esophagus. Next slide, please. Next slide, please. With a tapering end at its distal part and consequential pooling or stasis of contrast, all of which are findings that are characteristic of achalasia.
Manometry was also done, which showed a mean IRP, elevated mean IRP of 35, and there is no peristalsis appreciated with negligible pressurization. These findings were compatible with type 1 achalasia. Going back to the algorithm of our patient, this patient also had low surgical risk, thus options were discussed and patient opted to undergo POEM. So this is the POEM video of our patient. The LES was seen 45 centimeter away from the incisors, which showed the characteristic puckered appearance or rosette sign. After determining the LES, we proceeded with mucosotomy, which was done at 30 centimeter level. First, we created a submucosal bleb by injecting plain NSS admixed with indigo-carmine, followed by the mucosotomy itself, using a triangular tip knife in spray coag mode. Careful dissection of the submucosa was done, avoiding the mucosa and large blood vessels until 48 centimeter level was reached. Here you see the circular muscle fibers superiorly and the mucosal wall inferiorly. Myotomy was done at 35 centimeter level, 5 centimeters below the mucosotomy site to create a flap valve. Selective myotomy of the circular muscle fibers was done down to 48 centimeter level, that making sure that the myotomy goes beyond the level of the LES by at least 2 centimeters. In our patient, 3 centimeters. So before closing the mucosal defect, we checked the LES and documented smooth passage of the scope. This time, compared with baseline LES, the Z-line can be easily appreciated and the LES is no longer puckered. Finally, the mucosal defect was closed using 7 easy clips. As POEM includes myotomy of the esophageal circular muscles, perforation may lead to leaking of air and carbon dioxide to third space cavities, with pneumoperitoneum and mediastinum as most frequently encountered. Post-op pain is self-limited and managed conservatively. And some less frequently encountered complications include pneumothorax, bleeding, pneumonia, and cardiovascular events. Intraprocedural pneumoperitoneum is managed with a Veress needle to avoid compartment syndrome and should always be available during POEM. In general, POEM shows high clinical and technical success, as seen here from a 2015 meta-analysis. ACARD scores are significantly reduced. POEM is generally safe with less than 15% manageable adverse events with no POEM-related deaths among the included studies. Going back to our patient, he was discharged with no post-POEM complications. His diet was gradually progressed from general liquids and soft diet to regular diet at home. He also gained weight of 10 kilograms. He followed up after 5 months post-POEM and had an ACARD score of 0. A repeat esophagogram was done to be explained by Dr. Blanc.
This is the patient's post-POEM esophagogram done in our institution last February 2020, showing 2 endoscopic myotomy clips at the level of T7 to T8 vertebra on scout view. The barium swallow shows diffuse dilatation of the esophagus, now with uninterrupted passage of the contrast into the stomach. No evidence of any mass lesion or any irregular filling defect noted in the opacified segments of the esophagus. Next slide, please. Delayed study shows no evidence of reflux of contrast material. Next slide, please. So this is the comparison of the esophagogram done pre and post POEM. In your left, you can again see the bird's beak sign of achalasia, while on your right, there is now an uninterrupted passage of the contrast into the stomach.
Thank you again, Janine. Given the safety and effectiveness of pneumatic dilation and its local availability, it has been the procedure of choice for patients with primary achalasia. with POEM being introduced to the local practice, the advantages, disadvantages, and evidence on both endoscopic therapies should be taken into consideration. In this randomized controlled trial comparing POEM with pneumatic dilation in treatment-naive patients, POEM resulted in a significantly higher overall success rate in both short and long-term follow-ups. ECARD scores were also significantly lower with fewer retreatment strategies. Severe adverse events were not significant between the two. And as shown by our two cases, the first patient had symptom recurrence early on, while our second patient remained asymptomatic on short-term follow-up. However, development of reflux esophagitis was more frequent after POEM compared with pneumatic dilation. And POEM was associated with increased PPI use post-procedure. Yet these findings support that POEM can be considered as an initial treatment option for achalasia. In general, type 2 achalasia has a higher success rate compared with type 1 and type 3 achalasia as shown in this Kaplan-Meier curve. This table summarizes the treatment options based on achalasia subtype and current evidence. All treatment modalities are effective in type 1 and type 2, while in type 3, POEM has been shown to have the best clinical success. To summarize, we were able to present two subtypes of achalasia. We were able to show the different diagnostic features of achalasia. And lastly, we were able to exhibit two different endoscopic treatment for achalasia, which are both effective and safe. And as take-home points, the therapy of choice should depend on the achalasia type, local expertise, and patient preference. While both pneumatic dilation and POEM have excellent efficacy and acceptable safety profiles, pneumatic dilation will frequently require retreatment, while POEM has been shown to have better long-term clinical outcomes. And that ends my ERC presentation.
Thank you, Mark, from the LaSalle University Medical Center. May we now call on again Dr. Sara Presa to give a few comments.
Hello, good evening. Sorry, I wasn't able to prepare for the achalasia case, but congratulations for the very successful treatment of achalasia, both endoscopically and by both endoscopic treatment by pneumatic dilatation and by POEM. My only question is, when do you proceed with POEM right away, or when do you prefer to do pneumatic dilatation first? What are the subset of patients that would benefit more on pneumatic dilatation than POEM, or vice versa?
Okay, doctor. Thank you for the question, Dr. Sara. Based on my readings, basing on local expertise and availability, both can be initially done, ma'am. Either po. But since pneumatic dilation locally is more widely available, it has been the initial procedure of choice locally, Doctora.
Okay, from your take-home points, Mark, you said their therapy choice depend on achalasia type, local expertise, and patient preference. Can you go back to your two patients, because both of them are relatively young and similar, So what's the difference? Why was the first case pneumatic dilatation done? Was it patient preference or some other factors? And why was the second case POEM was done?
Yes, doctor.
I think that was the question.
Going back to our cases, the first case was offered both with pneumatic dilation and POEM, but due to financial reasons, the patient chose pneumatic dilation.
About on the achalasia type based on manometry.
Based on manometry, doctor, actually both could be offered for the patient. basing on success rates with type 2 achalasia, since success rates with type 2 achalasia are higher, they preferred pneumatic dilation as first. In one study, they preferred pneumatic dilation as first line for type 2 achalasia, doctor. But in literature and depending on local availability, both could be offered initially.
Okay, so there are a few questions in the chat box. Now let me read the first. For the first case, your primary impression was primary achalasia at the onset, but in the history there was long-standing history of reflux. Would you think a primary impression of peptic stricture is more feasible than considering achalasia right away?
Yes, doctor. Thank you for the question. This patient underwent an initial EGD, and he only told us that he had esophagitis without no anatomical abnormality. Therefore, the peptic stricture was not considered anymore during the history course.
Okay. Now for the last question, someone is asking about Heller's myotomy. Maybe you can answer this by comparing poem versus Heller's myotomy, advantages, disadvantages, and success rate.
Poem and Heller's myotomy are comparable according to my readings. They have comparable success rates. Actually, on current literature, laparoscopic Heller myotomy is currently the gold standard for treatment of achalasia, but that is only due because of still with limited studies with the poem, doctor, of regarding long-term outcomes and complications.
Okay, thank you. With that, we would like to end the presentation for the ERC for tonight. We'd like to congratulate the two institutions, Makati Medical Center and De La Salle University Medical Center, for presenting good cases and good discussion. We would also like to thank our radiology friends for attending. Now for the closing remarks, may I now call on our dashing Vice President, Julius Cosoriano. Come on down, sir.
Thank you guys for listening, and thank you to the presenter of De La Salle and Makati Medical Center. I would also like to thank Dr. Santi, who is answering in the chat box, who is giving us expert opinion. I think a lot of us really appreciate that, because sometimes we really need a expert opinion from our expert consultants. Now, so before we end, we'd like to hear from Mardi, the Senior Product Manager of HiSI. Mardi, can you say some words?
Yes, Doctor. Thank you, Dr. Julius Cosoriano. Again, I was introduced already. I'm Mardi once again, and together with me is our SFE manager and IT manager, Mr. Mike Dimaano. So first, congratulations to the presenter tonight, Dr. Mark Paulo Chato and his team, and also Dr. Mark Ryan Pasqua, for a very good and very interesting cases. So again, on behalf of HiSI, we would like to thank again the Philippine Society of Digestive Endoscopy for this great opportunity to be your continuous partner in endoscopic radiology conference. And as mentioned before, Dr. HiSI is a human healthcare company, and it is our commitment to be your partner in this kind of activities for continuous medical learnings and education. Again, Doctor, maraming salamat po, and have a great night to everyone. Thank you, Dr. Julius.
So, and then before we end, can I just announce September 10, we will have another ERC hosted by East Avenue Medical Center and Veterans Memorial Medical Center. So if you miss, if you reminiscence your days during ERC and you see how our fellows in training are being questioned, then I think it's also enjoyable and also learning for us to be here again on September 10, 5 o'clock again. And another invitation is on August 12. We will revisit the IEE, and our speaker will be a professor from Japan, Koichi Nonaka, and our own Kits Delusong. So they will be discussing about IEE on upper GI lesions. So I think it will be also very educational for all of us. So please see you again on August 12. We will be giving you the links when the days are near. Okay, so I think we ended on time so that we can do other things. Thank you very much to everybody. Thank you for the audience, and thank you for the presenters.